students, this is Dr. Prats. Welcome to my channel. Today we are going to discuss about wound healing in the oral cavity. How is it different from the rest of the body? Why is it unique? Is it because of the saliva? Does the microbiome in the oral cavity make any difference when it comes to wound healing in the oral cavity? Let's find out. What are scars? Scars can result either as a result of injury or because of any kind of trauma. And the most common scars which you can see is within the skin, yes? But in the oral cavity also we have wounds, and we will see how these wounds occur, how do they heal, and what are the different types. So first we'll understand by understanding what is the wound and what are the types of wound healing. Why we need to study, because there are a lot of surgically induced wounds in the oral cavity, as well as other pathologically induced wounds, and we need to understand how these heal in order to treat the patient properly. We'll see what are the types and the steps of wound healing, and we'll cover it with a summary at the end, and followed by how to answer multiple choice questions. These are the learning objectives. We'll start with defining the wound. We'll see the types of wounds, like I said, and the steps of wound healing. And we'll see healing of soft tissue wounds in oral cavity, as well as extraction wound healing. Any cut or break in the continuity of any tissue which is caused either by injury or by surgical operation is defined as the wound. I think that's very clear. All the tissues are continuous, isn't it? So if there is any break in it, it can be induced either by surgeon or by accident or trauma or something. That is called as a wound. Different types of wounds are there based on the causes. They're classified as mechanical if it is formed by an object, chemical if it is by any kind of, say for example, acid, thermal is by the heat, that is your heat burns and other wounds, and radiation is the wounds which occur because of the radiation. It could be in the form of a treatment, or it could be as an accidental exposure. So I just want you to understand a few types of the oral wounds. We'll start with abrasion, okay? Abrasion is basically caused by the friction or rubbing, okay? So you can see here, yeah? So this is an example of the abrasion. This leaves behind a very raw bleeding surface, but it is still partly covered by the epithelium. The second is contusion. You might have noticed these kind of wounds in your skin, because it's very easy to see. Whenever there is a very high impact wound, there won't be any cut or bruise or anything, but you just have kind of a hematoma, bluish kind of a discoloration of the skin. So that is called as contusion. This is because there is a submucosal internal hemorrhage, okay? This is very similar to the internal bleeding which happens in your organs whenever there is a big accident, okay? So similar thing can occur in your oral cavity also. Maybe, you know, some contact sports, or you fell or something like that. Laceration is produced by tearing. Okay, it's like a cut of the soft tissue, as you can see here. Maybe some sharp object has entered. Maybe there was a trauma, and that's how there is a tearing of the edges of the soft tissue. Avulsion is something that can happen both with the soft tissue as well as the hard tissue. Basically, the tissue is forcibly detached. So you can see here that this part of the soft tissue is like gone, it's lost. The same thing can happen with the tooth. That is called as avulsion of the tooth, okay? So the tooth just, whenever there is a trauma, it just comes out of the socket, and we'll discuss this at the end as a clinical implication. I'll discuss it with you, what happens when there is an avulsion of the tooth. And these were the types of the wound, and I just want you to understand the parts of the wound, because to understand the healing you need to know all this, okay? So this is a wound cavity, and this is just the same thing has been enlarged. So this cone, the apex of the cone is the base of the wound, and on the top is your wound edges, okay? And this is your surface of the wound, which can show many things: as slough, pus, blood. Many things can be seen on the surface of the wound depending on which stage it is. So that was about the types of the wounds, okay, which we see in the oral cavity. What about healing? What is healing? So this is the response of the body to injury. Why is the body responding? Because whenever there is an injury, the body has to restore the normal structure and the function back. And that is the reason why it has to heal. And this healing primarily depends upon two things. One is the type of the tissue involved. You'll have to go back to the types of tissues, stable cells, labile cells, permanent cells. So based on all these type of cells, whether they can undergo regeneration or repair, the healing occurs. And the second is depending upon the tissue disruption and the wound closure. Okay, so this is the basis of the classification or the types of wound healing, based on how the wound was closed and what was the amount or the type of tissue disruption. So we'll see what is regeneration and repair. So these are the two different types of healing, basically. Okay, so regeneration, the name itself says regeneration, meaning the same specialized tissue which is around the damaged area will regenerate to replace the lost specialized tissue. Okay, so when this happens, they're structurally and functionally indistinguishable. Both the lost tissue and the replaced tissue are indistinguishable from the surrounding tissue. The best example for this would be your hepatocytes, that is in the liver, and osteocytes in the bone. So these are capable of regeneration. Other than these two organs, rest of the body undergoes what is called as repair, because here the lost tissue is not replaced by the same type of specialized tissue, but instead by a granulation tissue. And this usually heals by scar tissue. And even structurally, it is different because it is coarse and it will have a very low cellular content compared to the surrounding native tissue. So like I said, except for bone and liver, all other parts of your body undergoes healing by repair, okay, including your oral cavity. That's something you should know. Why oral cavity wound healing is different from other parts of the body? Because it is very, very unique. It has both adaptive immunity and innate immunity. There is a mechanical barrier which is protecting it from all the microbes which is present in the oral cavity, and there is saliva around it. So there are three different types: primary intention, secondary intention, and tertiary intention. So we'll see one by one. So primary healing, it basically occurs whenever it is surgically induced. When a surgeon has given an incision for some reason, either to treat or to take a biopsy or to kind of remove some unwanted tissue. So any reason, but when the surgeon has placed an incision, it undergoes healing by primary intention. It is clean and uninfected because whenever we're doing any surgery, we take all the precautions so that there is no secondary infection, and the wound area is very septic when we are operating, isn't it? The loss of cells and tissue is not too much. And after we finish, if you know, usually the wound's edges are approximated by using a suture, right? So we use sutures to approximate the wound edges. So all these features are very typical of primary healing. So in secondary healing, it's exactly opposite. The wounds are open and it is a very large tissue defect compared to the wound which we see in primary healing. There is an extensive loss of tissue and the edges of the wounds are not approximated. So this is one of the main differences. There is no suturing in secondary healing. And there is no guarantee that the wound will be clean and uninfected in case of secondary healing. There is a slight difference with the tertiary healing. What happens here is that the surgeon uses it as a part of the treatment. Okay, this you'll study more in oral surgery when you go to that subject, I think in oral surgery 2 or 3. But what happens is we leave the wound open for a period, mainly for the reason to drain it, okay? Drain it, and then the lesion gets filled with the granulation tissue, and then the surgeon closes it. So this is an intentionally left open wound. So that is called as healing by tertiary intention. What happens as soon as there is a cut or incision, or whenever there is an opening for any kind of healing for that matter. So the blood fills up, and then the blood undergoes what is called as clotting. You know the clotting mechanism already. So after that, what happens? So in case of primary intention, we are starting with primary intention. Please look at the images. It'll be easy for you to understand. Within 24 hours, neutrophils first appear in any kind of acute inflammation, okay? So they appear all along the clot. This is the clot. How can you make out? There are a lot of red blood cells here. And these blue cells, yeah, these are the neutrophils. And by day 3, what happens is that all these neutrophils are replaced by the macrophages, okay? And by day 5, there is a granulation tissue which is replacing this area. You can see that this clot is disappearing, and it is being replaced by fibroblasts, which are laying down the collagen. There are a lot of blood vessels, okay? So this is nothing but the granulation tissue. Fibers, fibroblasts, blood vessels, inflammatory cells, all this together are called as a granulation tissue. Okay, so that happens by day 5. By the second week, there is a lot of proliferation of fibroblasts. There is extensive deposition of collagen, as you can see here. And by the end of the first month, it is completely replaced, as well as the epithelialization is complete on the top. Can you see the difference? Yeah, so this is healing by primary intention. All this has happened because the wound edges were approximated. It was clean and uninfected. Let's see what happens in secondary intention. Okay, so this is a repeat of the pictures we see in the healing by primary intention, and this is the healing by secondary intention. The first stark difference you can see is that the wound is very, very large and it is open, meaning the edges are not approximated by using sutures. And you can see that the inflammatory cells are much higher in number in case of healing by secondary intention than healing by primary intention. And even the granulation tissue which is formed is much bigger when you compare it with the primary intention. A lot of blood vessels, more inflammatory cells, and more fibrosis. So the wound kind of undergoes contraction, and the epithelium which results could be thinned down and could result in scar formation, especially in the skin, in the dermis area. You know that there is vermilion border which has both skin and the oral mucosa, right? So some of the examples of oral wounds which undergo healing by both primary and secondary intention could be healing by after you take a biopsy. Biopsy is done mainly for microscopic examination and diagnosis. You either remove the whole tissue or you remove just a part of the tissue. So other examples which undergo healing by primary or secondary intention is gingivectomy and frenulectomy. This is again, surgeon induces these things either as a part of treatment or it could be part of a procedure which we are undergoing. Like frenulectomy can be done as a part of orthodontic treatment where the frenum, if it is closely attached to the teeth, then that is excised. Okay, so that is called as frenulectomy. So this is an example of the tertiary wound healing. You can see that the wound is quite big. It is open. So this is epithelium and there is a break in the continuity of the epithelium. That's nothing but the wound, yeah? So there is a large gap between the edges of the lesion. Here you will see extensive granulation tissue. Can you see these structures here? Yeah? These round structures are your blood vessels, okay? These dots are all your inflammatory cells, okay? And these are your collagen and fibroblasts as well, okay? So this is nothing but your granulation tissue, and there's a very thin layer of epithelium which is formed on the top. And this epithelialization continues, and there is a union of the edges of the epithelium here. And further, there is a fibrosis of the connective tissue, meaning there is an extensive deposition of the fibers in the connective tissue. Okay, so that is the final maturation of the wound. There is a slight difference between the oral mucosa and the skin. It is because of the role of periostin. Okay, so this periostin has different roles in oral mucosa and the skin. In skin, it causes a slower healing and scar formation because of the role of myofibroblasts induced by periostin. Whereas in case of oral mucosa, it doesn't really induce any myofibroblastic activity. So there is a rapid restoration of the barrier, that is your epithelial barrier function. And the fibrosis in the connective tissue is also quite minimal. That's what doesn't lead to scar formation in the oral cavity. Okay, so that's a very important difference between skin and oral mucosa. So next we'll move on to the healing of extraction wound, or whenever you remove a tooth, how the socket heals, okay, the bony socket which is left behind. So as soon as you take out the tooth, again, there is a lot of bleeding into the socket, and the blood, of course, undergoes coagulation or a clot which is formed. And a fibrin meshwork is formed on top of it, which acts as a scaffold. There is vasodilation within 2 days because of the engorgement of blood vessels in the remnants of periodontal ligament. You know that whenever the tooth is removed, the attached periodontal ligament fibers, that are torn, and there are blood vessels in it, and that's what kind of bleeds into this cavity. There is also mobilization of the neutrophils, as we discussed in the soft tissue wound healing. And if you've seen, or if you've undergone the extraction yourself, the gingiva, the unsupported gingiva on the top of the bony socket is either sutured or it is left to kind of collapse. Okay, this basically protects the clot which is within the socket, which is very important for healing. And in the first week, there is a lot of proliferation of fibroblasts, and these fibroblasts go into the clot. This is the C for the clot, okay? So this forms kind of a scaffold, and this scaffold is slowly replaced by the granulation tissue, as we discussed in the soft tissue wound healing as well. This is the crest of the alveolar bone, okay? So this undergoes slow resorption. The osteoclastic activity begins. These are the cells which causes resorption. Also, the epithelium proliferates from the edges, okay? So the gingiva which is kind of collapsed on top of it, all right? So all this happens within the first week of the wound. This L and B are nothing but the buccal and lingual wall of the socket, and PM is the provisional matrix. Basically, it's nothing but it contains granulation tissue, there's some osteoblastic activity, everything together, okay? And in the second week, more and more blood capillaries invade the clot, and it becomes completely organized, and even the trabeculae starts extending outwards. So this WB is for the woven bone, okay? So it is an immature bone which is deposited basically, okay? And it starts filling up from the bottom of the socket, and it starts filling towards the top of the tooth. And more prominent osteoclastic activity is seen at the crest of the alveolar bone, as you can see here. And of course, the epithelialization continues. And any remnants of periodontal ligament, if at all they were here in this area, attaching the tooth to the bone, they all undergo degradation. This happens in the second week of the extraction wound. In the third week, the clot is completely replaced by the granulation tissue, which has fibers, blood vessels, inflammatory cells, fibroblasts, all of this, okay? And there is a woven bone or poorly calcified bone at the wound perimeter. And at the crest, the bone is completely rounded off, and epithelialization is also complete by the third week. In the fourth week, there is what is called as remodeling of the bone. That is, the alveolar socket gets filled with the new cortical bone. Okay, so this is the socket bone, and it is filled with the new bone. and this is the mandible. So all this bone which is deposited in the beginning is very poorly calcified. It is not strong like the rest of the bone surrounding, and it usually appears radiolucent. So that the sclerosis has not happened. So only after 6th or 8th week after extraction, that is after 2 to 2.5 months, you will start seeing the bone deposition on the radiograph. Okay, and you can see that there is complete healing of the extraction wound, as well as there is a flattening of the crest of the alveolar bone as well. What can be the complication while you're doing extraction of a tooth is dry socket. One of the instructions which you must give the patient, not one, quite a few instructions. So they are not to spit, because that's going to create negative pressure in the oral cavity. If you keep spitting, there is a chance that the clot which is in the wound is going to be lost. Okay. The second is, do not use any straw to drink your fluids, because that's again going to create negative pressure and might suck the clot out of the socket. Okay, so these are some of the things which you must tell the patient, not to gargle rigorously, because some patients do not like the taste of the blood and the smell of the blood in the mouth, so they keep on washing their mouth repeatedly. That will again result in dislodgement of the clot. And as you studied till now, clot is the most essential thing for wound healing, correct? So if the clot is dislodged, the healing does not happen. Okay, so that's what results in the dry socket. There are other names of it: alveolar osteitis, localized acute alveolar osteomyelitis. And the incidence is somehow more common in women and more common in people who smoke compared to others. And it is usually associated with traumatic extractions. So like I said, the clot is either lost or it undergoes lysis. That is followed by activity of anaerobic bacteria and plasmin. This is what results in the pain and the foul smell and everything that happens with the dry socket. So those were the clinical features which I was saying. So there is a foul odor. There is bone necrosis which is exposed, and that is why it is called as a dry socket. It appears dry. Another reason, there's no suppuration, there is no pus, blood is lost and there's no fluid in it. That is another reason why it's called dry socket. Very painful condition. There could be fever and lymph node enlargement as well. So the patient comes back to you within like few days complaining of all this. So how do you first prevent it, and then later we'll go on to the management. So like I said, it usually occurs in difficult extractions, right? You have to take a lot of care so that there's minimal trauma, minimal loss of tissue, whether it's soft tissue or hard tissue. Then you can avoid this situation also by giving very clear post-operative instructions to the patient to keep the gauze for the 30 minutes. Do not spit, do not drink anything with a straw, do not gargle your mouth immediately. All these are very important instructions. How do you manage? Okay, still the patient comes back with this. You keep the extraction socket clean by irrigating with warm antiseptic, and then you fill it with obtundant dressing. Usually zinc oxide eugenol is used. Many things are used. Many people keep a lot of drugs in it, but the most popular one, I guess, is zinc oxide eugenol. Do not get overwhelmed. It's very, very easy. So as soon as there is a wound, there is bleeding into the wound, which becomes a clot. That clot becomes organized into a granulation tissue, and eventually granulation tissue undergoes fibrosis in the connective tissue, and on the top, the epithelialization is complete. This is a soft tissue wound. And in a hard tissue wound, it's the same thing, just that there is some amount of bone deposition as well, because it's a hard tissue. Okay. I've just put a table for you to understand very clearly the difference between the primary and secondary healing. Cleanliness is very important. Here it's clean and uninfected because it's induced by a surgeon. Here it's not clean and it is usually infected because it's exposed. And sutures are used in primary, not used in secondary. Granulation tissue is kind of limited in primary, whereas here it's large. And the scar could be a result of primary healing in case of skin especially, and irregular wound in case of secondary healing. Okay, complications are not frequent in primary because so much care is taken, but it's usually quite common in healing by secondary intention. I think that will help you for a quick revision. So let's see how a question could be asked here and what is the answer. Suppose an oral wound is intentionally left open to allow drainage and is closed using sutures later. Then what does it heal by? So, primary, where we are using sutures immediately. Secondary, no sutures are used, it is open wound. In tertiary, we are intentionally leaving the wound open so that there is drainage, and then later on we complete the treatment by suturing it. So that's what heals by tertiary intention. This is just to distract you. It is there is nothing even called quaternary intention. Okay, so that's just an option to get you confused. Okay, so that's the end of my presentation. These are my references. I have referred to a very famous article on wound healing problems in mouth as well. Thank you and keep smiling.